Hi everyone, it's Richard here to bring another in-service, and this week we'll be discussing high flow nasal prongs. This was an in-service I was able to hold last week on the unit. I'd like to thank everyone that was able to attend, and I promised that I would record it and try and upload it so everyone else could have access to this, so here we go. So high flow nasal prongs, we've just seen a rise in its use over this winter period, given that we've had more patients present to the unit with respiratory type issues. And given that B22 is primarily a gen surge unit, specialized in urology and gynecology and various other things, respiratory is not really the predominant specialty here. So I just thought I would just like to take this opportunity to discuss some of the theories and components and some of the policy aspects regarding high flow nasal prongs, because I think it's one of those things that everyone knows little bits and pieces about it. But hopefully, if there are some gaps in people's knowledge, we can just sort of connect those dots and improve our knowledge so we can give the best possible care for patients that need to undertake this intervention. And let's get into it. Of course, wouldn't be an in-service by myself if I didn't start with an obscure quote from a book that looks really good on my shelf. So, the Stoic philosopher Epictetus has once said, "If you want to improve, be content to be thought foolish and stupid." And what does that mean? It's okay not to know everything at first. Asking questions and practicing is the path to mastery. I do find in this profession that when you get to a certain level in terms of years, you are a bit afraid to learn anything new. You just seem to think, I don't want to go back to that stage of feeling like a novice. I've gotten comfortable. I know my craft. I don't want to learn anything new. And I would just like to try and break that sort of mentality. I'm not saying anyone does that in B22, but I just have observed over my career. Sometimes we're a bit reluctant to learn new things because we don't want to feel silly. We just don't want to go through that sort of beginner phase again. And one of my reasons for doing these in-services is to help improve my knowledge about things. So if there's anything that you feel you're not too confident in learning, just be aware that sometimes we just have to accept that we may feel a bit foolish at the beginning, but over time, as we get more exposure to these things and just keep asking questions, that'll just improve our knowledge. And let's try and learn together. But what are high flow nasal prongs? So they are devices designed to help deliver humidified and warmed oxygen at high flows. And two settings that we will discuss later on is the flow and the FiO2. So the flow has a range from 10 to 60 liters, but on the ward, the policy states that the limit is 50, and FiO2, which again we'll discuss very soon, has the machine itself has the ability to deliver either from 21 to 100% FiO2, with the limit on the wards being 40%. And you can see in this image that's pretty similar to most of the units that we have here in B22. And interestingly enough, I believe we don't actually own any of the units that we currently have on the ward. They seem to have been deployed from other units, and they've just seemed to have just stayed here. And I'm in the process of reorganizing where these machines live and their stock, and I will send out an email about that very soon. Now this slide just breaks down the components of the machine itself. So you can see in that sort of top image on the left, we've got the interface part. Lower down, we have the pole, and not all of these poles seem to possess this sort of mounted tray, which is a shame because you can stock the items that you need to set up the machine in that sort of tray. And lower down is just something I'd like to highlight to people. There's an area there with the air filter. So that little white square that has been sort of lifted out from the device itself, that part actually needs to be changed every now and then. So when you turn on the high flow nasal prong machine, on that, so again, going back up to that first image where it says display, every now and then it might say change air filter, and it's referring to this bottom image here. And I hope you can read it there. There is that, again, that little white sort of rectangle. That is the air filter. We do possess some of those. And if people are unaware of how to change that or where they are, just come and see me and we can talk about it. Or if you ever see that notice displayed on there, change air filter, we can go through that, because that is one of those things that captures bacteria when the machine is in use. And if we are not cleaning and operating these machines as they are meant to, if you use this machine again and it hasn't been properly cleaned or set up, we are really risking spreading bacteria to our patients that need these machines. So I'm not going to go over every single component of this slide, but it is there if you do want to know more information about how the machine itself is sort of structured. So just quickly, how does the high flow nasal prong system work? So on this far left, you can see that there's the air and oxygen sort of delivery device going down towards where the humidifier, and then you can also see the image there of sterile water. So water, air/oxygen is combined there, goes through the circuit towards the patient where it's delivered through the nasal cavity and going into the lungs, and helping to promote oxygenation through delivering this flow, FiO2, using some PEEP to keep the airway, the alveoli open. We will be discussing PEEP a bit further down the line. So that's a sort of basic and extremely quick sort of discussion about how the high flow nasal prong system works. But why would our patients be needing the high flow nasal prong? I guess that's always an important aspect to go over. So just going through these points: hypoxemia, respiratory failure. So if the patient essentially has a low saturations, if they have poor tolerance of any oxygen masks as well. Sometimes post-op hypoxemia will be an indication for using the high flow nasal prong system. If they're producing secretions as well, that's enough, and they need help promoting clearance with that. Any chest trauma, palliative symptom relief, and if they're being weaned down from any CPAP ventilation devices, which wouldn't be occurring here in B22, but that is just one of the indications that's being dragged across from the policy that I was making these slides from. But of course, if you've got indications, you also have contraindications. So what are the reasons why we would not be using the high flow nasal prong system? Well, let's go through these bullet points together. The first one, facial and skull fractures. So if the patient has sustained some sort of facial injury, you do not want to be putting on any sort of tight binding oxygen therapy delivery device that might be exacerbating their symptoms. Now, I'm actually going to skip pneumothorax. I'll come back and talk to that one a bit more in depth, but we'll go down to hypercapnia, type 2 respiratory failure. So if the patient is having an issue, not so much with not being able to get oxygen in, but if they have too much CO2 in their system, giving them high flow oxygen is not a great thing to use to undertake, as you'll be promoting more CO2 building up in the body, and they'll become hypercapnic, leading to confusion, and they'll be needing eventually an ICU assist and then needing to go on BiPAP to get rid of that CO2 from their system, which we do not do here in B22. They would have to be transferred to ICU. If they've got a reduced GCS, as their airway may become affected if they've got a compromised level of consciousness, so the high flow is not going to help promote any sort of airway support. If they're hemodynamically unstable, so that's basically the same reasons for the reduced GCS. And if they're non-compliant or agitated, so if you've got people with, I don't know, dementia, Alzheimer's, or some other altered GCS state due to delirium, if they're constantly removing the high flow, they're not going to be able to get that oxygen promotion that we want. So just going back to the other point, pneumothorax there, you can see in this image we have one healthy looking lung right on the right, and on the left we have a shrunken lung due to a pneumothorax. So the pleural space is pushing against the lung. There is air filling in there. And I'm only highlighting this one because recently we had a patient here in B22 in bed 2 who sustained a motorbike accident. He fractured a rib, he sustained a pneumothorax, but then he came to the unit on high flow nasal prongs. So if you're thinking, you just said we shouldn't give high flow nasal prongs to people with a pneumothorax. Yes, but that patient he had a chest tube. So he had a drain into that pleural space, which allowed the air to be filtered into the chest drain and allowed his lung to re-expand. So what would happen if you put the patient on high flow and they had a pneumothorax without a chest drain? You were pouring in pressurized oxygen into the lung space, but it cannot expand due to that pleural space pushing against the lung. And if you think about what would actually, if you have two forces pushing against each other, you are about to cause another big issue. That would be leading to a tension pneumothorax, and we would be in big trouble if that happened in our unit. So that was just something to be aware of. And also just probably expanding a little bit more on point 3, the hypercapnia. Just last week, there was a MET call for a lady who had a high rest rate, background of COPD. We were pouring oxygen into her just to try and get her sats up. But during the MET call, when we did an arterial blood gas, her CO2 in her bloodstream was 100, which is really bad. So basically, she just had so much CO2 in her body, and her lung capacity, the ability of her lungs to filter that out was just so impaired that it couldn't happen. So she ended up needing urgent transfer to ICU to have BiPAP commenced. When you turn on the machine, you will see these 3 numbers with their different colors. On the far left, that 37 degrees Celsius, that refers to temperature. The one in the middle, that refers to flow. And the last green one refers to FiO2. So now that I'm sitting here talking about this, I really should have rearranged the FiO2 and flow. And in these next couple of slides, we will go over a bit more detail about each of these settings. Let's talk about temperature. Now, when you have your patient on the high flow nasal prong, you will see the stock image that I've used on the background here. They will look just as happy as this guy. Now, if you've ever looked after someone with high flow nasal prongs, you will know that's not true. The range of the temperature can be set from 31 to 37 degrees Celsius. The warm and moistened air prevents mucal drying. It maintains mucociliary clearance, and this is important because this keeps the lungs' natural clearing system working. High flow nasal prong temperature and the humidity settings, this prevents airway drying. It ensures that the secretions, they remain mobile, and the cilia, which are the little sort of finger-like tendrils, I guess, in the airway, make sure that they can do their job. It reduces the risk of plugging, infection, and any respiratory distress. So basically, when it turns on the machine, I think pretty sure it auto sets to 37 degrees, and we can adjust it a bit cooler for comfort if patients require it. Okay, if there was a bit of a lag or a pause in between these slides, I apologize, bit of a technical issue. Next one, we're going to be talking about FiO2, the fraction of inspired oxygen. Right now, you, me, sitting around the air that we breathe, it is built up of gases, and it is essentially made up of 21% of oxygen. We can actually manipulate the percentage of oxygen that is delivered to the patient. On the wards, the limit is 40% unless there's a special order by ICU or the respiratory team, and we can adjust this to maintain the target saturation levels. And for patients with COPD, this would usually be between 88 to 92%. We should really try to avoid unnecessarily high FiO2 settings, as it can lead to oxygen toxicity risks. And especially in our patients with a background of COPD, pouring more oxygen into them is not the way to go. As I was talking about the example of the patient on earlier slides, we hit this lady with quite high levels of oxygen, and then her CO2 level just really got to too dangerous a level to be managed on the unit, and she needed to be transferred out. So the way that we manipulate the FiO2, it's by adjusting the O2 flow rate from the wall outlet. So if you've never been able to if you've never had the opportunity, to use a high flow nasal prong device, we can go through it together. And then the oxygen tubing is connected to the machine itself, which leads to the oxygen delivery device. And as you manipulate the flow of the oxygen, so 2 liters, 4 liters, 5 liters, whatever you choose to set it to, you will see the numbers associated with the FiO2 on the interface change as well. And our last setting, flow, the liters of gas delivered per minute. And again, I'm emphasizing this a lot throughout this presentation, the limits on the unit. The limit for the flow is 50 liters. So the flow will meet or exceeds the inspiratory demand of the patient to maintain a stable FiO2. Now that complicated sentence basically means however fast the patient is breathing out, we need to meet that sort of strength of their expiratory effort. We either need to meet it or we need to exceed it so that we can maintain a good therapeutic effect of the high flow nasal prong machine. It flushes out the dead space, and dead space will be discussed in another slide, and reduces CO2 rebreathing. Flow also helps generate a low level of PEEP, and PEEP is what helps keep the alveoli open. Now let's just discuss what PEEP in a bit more detail. So PEEP stands for positive end expiratory pressure. Think of PEEP as like leaving a little bit of air in the balloon so it doesn't completely collapse. And in this sort of analogy, the balloon is the alveoli. So normally when we breathe out, our lungs don't empty all the way. They are still slightly open. But PEEP is the extra pressure we add at the end of exhalation to keep the alveoli, the tiny air sacs, open. This prevents collapse. It makes the next breath easier and improves the oxygen exchange. So I wish I had an animation for this slide. If you can imagine a balloon that's deflated, that is when we are breathing out. But what PEEP is trying to promote is to keep that balloon inflated even when we breathe out. So the surface area of the alveoli is always open, and it's helping promote that sort of gas exchange in the lungs so we can increase the ability for the blood to get oxygenated so the patient's condition can improve. Now, understanding dead space. Anatomically, the airways with no gas exchange, the nose, trachea, and bronchi, they can get filled up with air, but there is no actual gas exchange happening in that sort of space. And the high flow nasal prongs help wash out CO2 from that anatomical dead space, and this will result in better oxygenation and less work of breathing. I've been trying to think of a sort of simpler way to explain this, but I guess think of the lungs and think about if they have an area that they can be filled. Let's pretend it's a cup, okay, right? And then that cup can hold 500 mils of fluid. Now, the alveoli itself, in this analogy, account for 350 mils. Now, if you do 500 minus 350, you have 150. 150 is that other spaces in the lungs that aren't alveoli, they get filled up when we take a breath in. That is the dead space. And what high flow nasal prongs are trying to promote is in that dead space where CO2 can sit, we can help wash it out so the CO2 is hopefully not sitting in the system and preventing complications. Causing complications, sorry. Now I'm going to keep hammering this home. Ward practice and ward limits. FiO2, maximum 40%, flow 50 liters. ICU review is needed if settings need to go above this, and the treating team or ICU must approve the use of high flow nasal prongs. It's not something that can be nurse initiated, and we just need to be aware of any escalation or resuscitation plans that are in place. The reason I am going over and hammering home the 40 and the 50 liter limits is, look, obviously we could adjust it higher on the unit, no trouble. But really, what if a patient is requiring higher demands than these settings? They probably shouldn't be here. And if you think I'm going to solve a problem by just increasing this number here so I can get the readings that I want, you are tempting fate, because these patients are quite unstable typically, and you have to think about the demands of the unit and your patient load. If you've got someone with higher oxygen demands and they're becoming more unwell, and you've got 5 other patients or 4 other patients or however many, and this patient is dominating your time with observations, you need to escalate their situation, so they need to go to the more appropriate unit. It's not a question about us being able to manage one patient, it's about us trying to manage collectively our patient load. So if you see your patient's oxygen demands are increasing, that is a bad trend, and we need to get on top of it quickly so that this patient get the treatment they need, get to a more appropriate unit, and that also allows us to care for all of our patients, because we have a responsibility to the unit, not just to that one individual. On this slide, I've included a link to a video of a gentleman setting up the high flow machine. If you've never set up the machine before, this is a good video to watch. He does go through it in good depth. And it's just one of those things, I can't talk about it. It's probably best to watch it and to actually do it as well, to help get a good idea of what is involved in setting up the machine. So if you've never set up a high flow machine before, please watch this video. I'll include the links in the email, and also I'll share the slides and email as well when I send this out to everyone. And if you would like to try and set it up, if I'm available and we have a spare unit on the unit, we will do that as well, as it's just one of those things. It's better to do it in a controlled fashion where it's outside of a met call, instead of trying to get it done during a met call when the adrenaline is pumping, and then mistakes can happen. But of course, like anything we use here in the healthcare system, we need to monitor it. So just taking these points from the policy itself, and we'll go over them now. We need a baseline set of vitals before we start. At the beginning, we need 30 minutely obs for 1 hour, and then hourly obs for the next 3 hours. And then after that, we can do 4th hourly obs until we cease using the high flow machine. We are monitoring the rest rate, oxygen levels, heart rate, BP, and temperature, and so on and so on. We don't need to go through it all. Watch for any increasing needs of FiO2, and if they have a high respiratory rate, if the SATs are going down, and for signs of distress, then we need to be escalating the care. Check for kinks, leaks, and condensation in the tubing. And when we are documenting our observations on the EMR, make sure that we are actually commenting on the flow and the FiO2 settings at the time of when we check the observations. Eventually, if our patient becomes stable, we will need to wean and then eventually stop using the high flow machine. So with the weaning process, first we would aim to reduce the FiO2 first, and then the flow. So in terms of how do you sort of do it, a sort of stepped approach with reducing the FiO2, that's a tricky one. There is no sort of like hard and fast rules about how what sort of levels you should decrease the FiO2 down by. It is kind of dictated by how on the patient's condition. So it will be one of those case by case basis. But if you do have a patient and the team have documented, begin to wean down the high flow machine, please try and start doing it as well, because too often I see, not just here in B22, but even my previous ward as well, the doctors will be writing wean off, and then the settings would remain the same for shift after shift, and people would only turn it down when the team came. So if you have a patient who needs to be weaned off and you're not comfortable and unsure on the sort of approach you should take, come and grab me. But typically I would be reducing the FiO2, depending on what it was. Let's just say the FiO2 was 30, I would go down to 25, then down to 21, because that's the lowest it will allow you, and then essentially we can probably stop it. But then we also need to consider the flow. So it's one of those things, I can't give you any sort of hard and fast rules about it, but one thing for sure is we shouldn't be abruptly stopping it. We need to provide some equivalent O2, probably via the nasal prongs, not so much via the mask, after we have stopped this. And then even after we've finished using the high flow machine, we should continue obs fourth hourly after we've stopped it. And just a little sort of like tip as well. The machine itself, when you turn it on, you may have noticed that it takes quite a while to turn on. So if I was taking my patient off the high flow, I would actually be putting them on nasal prongs via an oxygen cylinder, probably for the first hour, just in case I needed to use the high flow machine again quickly. I don't want to go through the whole rigmarole of turning it on, which can take quite a while. It's just something to be aware of if you're a patient. You're not quite sure how they'll go off the high flow. Just some things to consider. Make sure you've got the right cannula size for the nose, making sure that we're keeping an eye on those points of pressure. So in this picture, we can see that this patient has sustained a pressure injury behind the ears. Make sure they're sitting upright and positioned well for meals, and encourage that oral hydration, because we want to keep that mouth clean. We don't want to be we don't want to see that area getting dry and then causing another issue like thrush that just could lead to a delay in their discharge and just extend their stay in hospital. Now, this slide has a link to another video about a woman here showing you how to clean and disinfect the machine itself. Please, please, please watch this one, because this is the area that concerns me the most, that people are just stopping the machines and they're just leaving them anywhere on the unit, and they're not getting cleaned appropriately. And then that just promotes potential complications. If we use it for the next patient, it hasn't been cleaned properly, because bacteria can spread through these machines if they're not cleaned properly. And the red tube that you can see in her hand, there is a second component to it that will be explained in the video. So make sure when you have a red tube, you will see that there is a small plastic sort of appendage that needs to go on it. Make sure that stays with it at all time and is not thrown away. Oh, I did not want to play that. Go to the next slide. Bit of troubleshooting now. So if you see that the oxygen is low, check the source, follow the tube. Is it attached to the wall? Check the cylinder if it's attached to one. Is that empty? Check for any leakages or blockages anywhere along the line. If the temperature is not reached, adjust the settings, check ambient temperature. Maybe the bag of water is empty as well. That happens quite often. And one issue that happened to me on the ward just the other day during a MEC call, the machine itself was actually set in the PEDS mode, so the junior mode. So this setting limits how high we can set the flow, and I'm pretty sure the temperature as well. So if it is set up in this, we need to get it out of that. You need to hold that play button, and once what does it say here? To deactivate the junior mode, hold the mode button for 5 seconds, and that should get us out of that and back into the adult setting. If we need to transfer our patient, there is no battery unit available for the high flow machine. Once it's plugged out from the wall, it'll turn off. So you need to find an alternative oxygen delivery device. So you need to get like the oxygen mask or a non-rebreather mask, turn in an oxygen cylinder, and use that till the patient gets to where they need to go. And if we're getting a patient from another unit with a high flow machine already in use, if the ward is calling to handover, ask them to bring across their chamber and the water bag with them, and then we will just have the high flow machine set up next to the bed ready to go, that we can just slot it in and get going. So to summarize, key points: high flow nasal prong, it delivers warm, humidified, high flow oxygen to help promote oxygenation and reduce the work of breathing. Know the ward limits and the escalation triggers, and our role really is to help with the setup, monitoring, make sure the patient is safe, and escalate any care. And I should have made the image a bit better resolution in the background. You can see this guy's got off the high flow and he's so happy, and he wants to thank the nurses, and he wants to do a survey to say that B22 gets 5 stars. And just some boring links to the hospital policy, and also there is a link there to the Fisher and Paykel Airvo 2 manual that I also grabbed some images for this slideshow. So I hope this presentation was helpful in some way. I will be continuing to try and deliver in-services in this fashion. And maybe the next few ones, I know I said this last time, but I will try and discuss potentially something gynecology or urology related. But I just want to highlight some things that are sort of outside of the specialty of B22 and just help promote a bit more learning. And I hope this was helpful in some way. And I'll see you on the next one. Thank you very much.